Hi, this is Elliot Fishman, and welcome to the December 2023 CTisus quiz. Where did 2023 go? Oh my goodness. Well, it's the last month. I hope you had a great year, and I hope you have an even better 2024. But let's not chit-chat. Let's go straight to the cases. We have 10 spectacular cases to close out the 2023 year. And without further ado, we're getting started. The most likely diagnosis in this case is, well, you see very nice cystic lesions well defined in the lungs, in the upper and lower and mid lung fields. This is not the sequel of COVID pneumonia. COVID pneumonia, when you have any changes, is usually interstitial. Cystic fibrosis, a dilated bronchi, that's not the appearance here. And it's not simply emphysema. This is not the look of emphysema. Well-defined cystic lesions, this is LAM, lymphangioliomyomatosis. If you looked at the patient's abdomen, perhaps you would see some renal angiomyolipomas. Just a very classic diagnosis. The most likely diagnosis in this case, this is an interesting case. You see a mass which touches the tail of the pancreas and the stomach. Now, in theory, this could be off the tail of the pancreas. If it's exophytic like that, you think of lymphoepithelial cysts, and this is somewhat cystic. So it's a thought. It's not going to be implants from ovarian cancer. I guess it could be implants with pseudomyxoma peritonei, but then you would see more findings elsewhere, not just this finding. It could be a pancreatic tumor, as we said, lymphoepithelial cysts. But when you look at this, it's really touching the stomach always, and at times you can not make the right call. GIST tumors are typically exophytic, though they can be intraluminal. The exophytic ones sometimes just seem to touch the stomach and not arise from the stomach, but this was a GIST tumor. It's a little bit low density for GIST tumors. They're usually more solid, can be a bit more vascular, but this was a GIST tumor and was resected. The most likely diagnosis in this case, in this patient with something going on in the left groin, is, when you look at the images, there are nodes and induration in the right groin. The left groin has bigger nodes, more induration, and this little needle tip. Okay, that's the answer. What gives you a needle tip? It's a broken needle. I guess maybe there was a surgical procedure being done, but with big nodes, and you can see them very nicely on the cinematic. This is not lymphoma. Low lymphoma obviously can give you nodes, but then you got to explain the needle. Melanoma can give you nodes. Postoperative abscess, I guess theoretically somehow or other, though unlikely. But once you see the broken needle, you may have had more clinical history as well. This is an inguinal abscess with nodes due to IV drug abuse. Again, look for foreign bodies. When you see foreign bodies in the inguinal regions or in the antecubital fossa or other areas like that, you got to be thinking of IV drug abuse. The most likely diagnosis in the 70-ish-year-old female is, I see a cystic lesion in the body of the pancreas, central calcification, and septations. Now, mucinous cystic neoplasms are great in the body of the pancreas. The patient's a bit old. They can calcify, but the spotty calcification in the center is a bit different. IPMNs typically don't have those septations or the calcification, and neuroendocrine tumor typically is vascular. Cystic lesion, no dilated pancreatic duct, central calcification. The best diagnosis is a serous cystadenoma. I do know you would have thought about a mucinous as well, but a serous cystadenoma is the right answer and the best diagnosis. Now, this was eventually resected. The patient had some symptoms. Serous cystadenomas are always benign lesions and can be left alone unless the patient is symptomatic. The best diagnosis for this case, 2 images. On the image on your left, the stomach is well distended. You look at the antrum, there's diffuse infiltration. I'm thinking tumor. Lymphoma, it could be. Adenocarcinoma, it could be. Ovarian cancer, well, could it be a metastasis? Then you see, as you scan lower, large cystic masses. Now, I have to admit, I'm going to tell you those cystic masses went down to the pelvis. So those are both ovarian masses. Now, you could say maybe the patient had primary ovarian cancer with mets to the stomach, but more likely with bilateral ovarian masses and the infiltration of the stomach. This is a Krukenberg tumor. It's a gastric adenocarcinoma with metastasis to the ovaries and fallopian tubes. Very, very nice example. In this patient with palpitations, the least likely diagnosis, well, I see a large right adrenal mass with some enhancement. The most likely diagnosis with the history is going to be pheochromocytoma. Yes, it's not your typical hypervascular lesion, but pheos don't have to be. Lymphoma unilateral is uncommon and wouldn't explain the history, but it's a thought. And a primary ACC, again, is in the differential diagnosis, surely. The thing that would be unlikely would be an adenoma. This is too solid. Yes, we get atypical adenomas or adenomas that had prior bleeding, but at the end of the day, the history of palpitations takes me away from adenoma, and the best answer would have been pheo. The least likely answer would have been an adenoma. And this, of course, I hinted that it would be a pheo. This was an ACC, an adrenal cortical carcinoma, yet the patient's presentation with palpitations. Again, adrenal tumors can be very, very tricky. The most likely diagnosis in this case, well, what do I see? I see an enlarged spleen with cystic and solid mass. Yes, it could be an abscess, and that typically is cystic. There can be stranding around the spleen. I don't see that, but an abscess is consideration. Melanoma, usually it's solid, but can be solid and cystic. Hamartoma is typically solid. When you see a large mass, solid and cystic in the spleen, you got to consider lymphoma first. This was splenic lymphoma, but I am going to say that abscess and lymphoma can overlap. Clinical history can be helpful. Also with lymphoma, sometimes you do get primary splenic lymphoma. Other times there's multiple other organs involved in adenopathy, so that could be helpful, and melanoma could not be totally excluded. The differential diagnosis in this case includes there's an infiltrating tumor in the region of the hilum involving the spleen with some duct dilatation. It's interesting, the mass is higher density than the rest of the liver, seems to encase the hepatic artery, seems to encase the region around the pancreatic head. Lymphoma is a good possibility. Lymphoma can infiltrate into the liver. Cholangiocarcinoma is a great thought. Maybe it would have been my first thought. Typically, infiltrating tumors, duct dilatation extending toward the hilum with adenopathy. Colon cancer, when it recurs, particularly right colon cancer or even a presentation, can commonly get nodes in the portal caval space and peripancreatic region. It's a bit unusual to have this much infiltration, but it's a possibility. So I have to admit all of the above is the best answer. I would have picked cholangio as my first thought. This was lymphoma. Lymphoma of the liver is uncommon by itself in a case like this, but it's something we should think about more frequently, and just a very nice example. The increased density to me really pushed me to cholangio, but I was wrong. It was lymphoma. The most likely diagnosis of this incidental hepatic mass is you see a vascular lesion on arterial phase imaging that nearly becomes isodense on venous phase. It's well defined and sharply marginated. It has a central scar. It's enhancing, but only as bright as the IVC, not as bright as the aorta. Hepatic adenomas, the enhancement is too homogeneous. Hemangioma, it's the wrong pattern of enhancement. Hepatoma, typically you get vascular lesions, but there's a regular enhancement, nothing so smooth. Every lesion can give you a central scar, but the lesion with central scar, quickly becoming isodense, hypervascular but only as bright as the IVC, and homogeneous, the answer is focal nodular hyperplasia. Just a beautiful example. If you would have got additional delayed scans, the borders of the lesion on venous phase would have disappeared and the lesion was totally isodense. The most likely diagnosis in this case, you see a 1 centimeter mass in the anterior mediastinum, really nicely shown on the cinematic rendering. Lymphoma can give you nodes, but an 8 millimeter or 9 millimeter node as the only finding, no way. Thymoma, in theory, it's a bit small, but thymomas can be small. That's a possibility. Teratomas typically are large, have fat, have calcification, have fat fluid levels, be the world's smallest teratoma in history. I think you're stuck here between thymoma and parathyroid adenoma. Because I really like this case and we published it, this was an ectopic parathyroid adenoma. Remember, parathyroid adenomas are usually by the inferior levels of the thyroid, but can occur anywhere down the mediastinum, and this is a great location. Just a beautiful example on cinematic rendering of an ectopic parathyroid adenoma. So with that, from all of us at CTisus, I want to wish you a happy and healthy 2024. We hope the year brings you everything you and your loved ones want. And we'll see you next month. See you in 2024. Bye, guys. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.